Okay, so we've got a wonderful lineup today with presentations from Bhutan and Nepal, and finishing with a live panel discussion. Our first presentation comes from Bhutan, and I'm delighted to introduce our first speaker, Dr. Sonam Zangmo. Sonam is an infectious diseases physician at the National Focal Point for AMR in Human Health in Bhutan. In this role, she's used data to inform policy, including the development of policy briefs on reducing healthcare-associated infections to combat AMR. She has driven the establishment and strengthening of national systems for AMS and IPC, and through sustained leadership and advocacy, she has translated evidence into action, helping establish Bhutan's national AMS and IPC Centre as the country's coordinating hub for AMR, which she currently leads. Unfortunately, Sonam's unable to join us online this morning due to the time difference. It is 4:30 a.m. in Bhutan. So here's a pre-recording of her presentation. Please send through your questions and comments, and we'll be more than happy to pass them on. Thanks, Caroline.
Okay, a very good morning and greetings to everyone all the way from Bhutan. So now, without wasting much time, I shall straight away take you through my presentation and share Bhutan's experience in evolution of AMS through use of meaningful data that's been captured through the NAPS tool, that is the National Antibiotic Prescription Survey tool developed by the NCAS. So let me begin with a story. Towards the end of 2023, Bhutan was facing a silent health emergency, especially at the National Referral Hospital, an emergency which was invisible to most. That was the MDRO crab, which is the Acinetobacter baumannii. But somehow my colleagues here, they became very comfortable with the pathogen and they have nicknamed it as Acinetobacter Bahubali. Bahubali, that's the famous epic Indian movie, and which was quite alarming because instead of being alerted, they were becoming comfortable with the pathogen. And this is the culture report that was seen mostly in the National Referral Hospital. It's not that we didn't have the carbapenem-resistant organisms before. We did have few cases. In 2019, we had 13, and 2021. But in 2021, we just 8 cases. That's thanks to COVID, that all the infection prevention control measures, the supply of PPE was all strengthened, hand hygiene was at its best, medical tourism was put into control, and visitor control was also taken care. And that's why we had the number come down to 8. But come 2022 and 2023, the number started increasing. And in November 2023, within a span of 1 month, we had 29 cases of CRO, of which 17 were crab. And as usual, when we always talk about AMR, what is the first thing that comes to your mind? Isn't it that it has been created? And by whom? By the doctors, of course. And how? By prescribing antibiotics inappropriately. Now, this must have been true then, and it might not be true now for our country. It must have been true for some of the countries across the region, but it might not be true for Bhutan in particular. But how do we prove ourselves, especially when we are sleeping over data, not because we like to sleep, but because we lack the human resources and the time and the capacity to interpret meaningful data, and more so we lack the innovative tool to analyze such data. But for Bhutan in particular, we were able to say, look, this is not just about the inappropriate use of antibiotic. This is something more than that. It's not just about antimicrobial stewardship, but it's about having systems in place, having multi-sectoral approach in combating AMR. And thanks to the NAPS tool that's been developed by the ICAS in collaboration with the Peter Doherty Institute, also caters to the hospital NAPS and surgical NAPS and quality improvement NAPS. For Bhutan in particular, we had the answer. We had the answer to say things have evolved beyond the misuse of antibiotic, beyond the inappropriate use of antibiotic, because our data clearly through the help of NABS says that in the National Referral Hospital, our appropriate use of antibiotics was as high as 80% in 2024 and as high as 90% in June 2025, which is at par with some of the developing countries in the world. And similar trend in all the sentinel sites for AMR in the country. When it comes to the AMC data, again here you will see the use of SS group of antibiotic was more than 80% in the last consecutive 5 years, which is way above the WHO target of 70%. Now, NAB says our appropriate use of antibiotic is fairly high, more than 80% in all the sentinel sites for AMR in the country. IPC, the HAI, is below 12%, which is, much better than most of the countries in the region. And microbiology, we boast of ourselves of having good diagnostics, especially that we have the multi-TOF in place. So what we failed to answer, where is the problem? And when we had a deeper analysis, when we had a deeper interpretation, we said, look, we have passed the phase of spreading AMR and we now live in the phase of spreading AMR. It's not just about inappropriate use of antibiotics, but it's not just about antimicrobial stewardship in place, but it's about the infection prevention control, the diagnostic stewardship, the quality assurance division working together. So that's when we realize the problem is a system problem. The problem is the lack of synergy between the infection prevention control, the AMS, the diagnostic stewardship, and the quality assurance division. And then we came up with a rather policy brief that we came up with a neutral topic saying it's better to say poor IPC leading to AMR. So we rephrased it as reduction in HAI to combat AMR. And we have come up with a beautiful piece of policy brief, which is one of the first kind developed in the country, which is easily accessible in the website in the WHO. And we have named it Combating AMR through the Control of HAI in Bhutan. And due to such policy brief, we could successfully change systems overnight. We could put systems in place. And for Bhutan, our policymakers and administrators, it's just that they're ignorant because we fail to provide data to them. But once we give them data, they're very proactive, very understanding, very supportive, and they make, like during the COVID times, our country had a track record of vaccinating almost 99% of our population within a span of 1 week. So as long as we have the data in hand, as long as we have the information to guide the policy, we are good at doing wonderful tasks, especially for Bhutan. There is strength in smallness. An outcome of the policy brief and the use of all the many meaningful data through the help of NABS, overnight we saw the change. From what was just the infection prevention control working in silos in 2012 and an additional of AMS in 2016, we now have the IPC and AMS unit, which consists of the diagnostic stewardship, quality assurance division, the IPC and the AMS team. And not just that, we didn't stop there, but through all this policy brief, we now have the National Antimicrobial Stewardship and Infection Prevention and Control Center at JDWNRH, which also serves as the National Coordinating Center for AMR in the country. So we have a set of dedicated teams working closely on a daily basis, and not just at the National Hospital, but in all the sentinel sites for AMR in the country. So every day, the dedicated team, the dedicated multidisciplinary team conducts meetings, and they provide TOTs, their training and education and awareness to the clinicians, to the supporting staffs, and to the public at large, not leaving the military hospitals as well. And we have now the real-time surveillance for carbapenem-resistant organism, also linked to the HAI surveillance and AMR surveillance, to give timely feedback and guidance to the clinicians and the administrations and the policies. We've also developed guidelines, especially the management of carbapenem-resistant organism, one of the first of its kind in the country, and also produce time-to-time surveillance report to guide the clinicians and the administration and policymakers in the. So, because through use of all this meaningful data, we could successfully create the cohort isolations, and not just sticking to cohort isolations, but also implementing respiratory and non-respiratory cohort isolations. We have now a very strong collaboration and communication between the diagnostic team, between the clinicians, between the IPC nurses, and the patients in large. Of course, we always do the auditing and feedback in the form of circulars and in the form of reports that are used in a very productive way. And today, what used to be a one man's dream, a one man's vision, has now into the dream of the entire family, entire health fraternity. And through the support of the Flaming Fund and the NCAS and the Peter Doherty Institute, and of course the NAPS tool and the IVI, I should say today we proudly have many leaders who had no title, but working towards a shared goal, that is to combat the AMR in the country and in the region. And to have a sustained effort, I should say, data must guide policy, and the show must go on. For Bhutan, the show shall go on with this team. Thank you for giving me the opportunity to speak. Thank you.
Presentation, that's really good. Thank you, Sonam, for that presentation. We'll turn to our next speakers. So our next presentation is from Nepal, which brings two speakers from the National Academy of Medical Sciences, or NAMS, in Acharya Hospital in Nepal. Jyoti and Sangita are also unable to join us live this morning. Also, due to the time difference, it's actually even worse. It's 3 a.m. in Nepal. So we have a pre-recording of their presentation for you. As before, please send through any questions and comments in the Q&A box and we'll pass them on. So just a brief introduction for each. First, Associate Professor Jyoti Acharya holds a PhD in Microbiology from Bhutan University and serves as Chief Medical Technologist and Head of the Microlab NAMS via Hospital. She sits on both of the AMS Program Core Committees and its Governance Committee, and has previously served as the AMR Lab Focal Person and the National Public Health Lab, and completed the Fleming Fund Fellowship hosted by the Doherty Institute here in Melbourne, and is also the recipient of the WHO Asia Regional Sort It Fellowship, through which she has published on AMR surveillance and quality improvement. Alongside her is Associate Professor Sangita Shrestha, who holds an MSN in Medical Surgical Nursing from Bhutan University as well, and serves as the Chief Nursing Administrator and Nursing Director at NAMS via Hospital. Since 2023, she's been the AMS Program Coordinator, chairing the AMSP Core Committee and acting as Member Secretary of its Governance Committee. Her work spans supervising antimicrobial audits, developing local antibiograms, and contributing to guidelines and training manuals. She's also the institutional focal point for IPC. Thanks, Caroline.
Good morning, everybody. Me and Associate Professor Sangita Shrestha are going to present today on AMSP program at our hospital with its issues, constraints, and the road to success. This is our outline of the presentation. I'd like to introduce our hospital, which is one of the oldest hospitals established in 1889. It is one of the largest tertiary care hospitals, a government hospital that serves millions of patients annually. And in recent times, it has become the major academic center for medical, nursing, as well as other allied health professionals. The hospital capacity is 960 beds, and it provides basic, specialist, as well as super specialized services through 22 clinical departments and 3 clinical units. We have ICUs too, with 72 multi-specialized ICUs and 38 high-dependency unit beds. Talking about AMSP activities, it all started in 2023 when we formed the AMSP Core Committee. After that, we found the need to form a governance committee for better implementation of antimicrobial stewardship within our institution. For that, we have started by doing our analysis of strengths, weaknesses, and threats to our AMSP activities, along with finding opportunities for the same. We prepared a tentative work plan for the future and provided orientation to the various hospital staff on AMS. In 2024 October, Captura 2 project got TASE involved, which included a clinical engagement training for the AMSP core committee members. Talking about the governance structure for the AMSP, it is headed by the director, who is the chairperson, and the nursing director, who is the member secretary. We have members including deputy director, heads of various departments, AMSP core committee members, and also the administrative staff. The core committee at present is functioning and has 2 clinicians, 1 microbiologist, that is myself, 2 nursing personnel. Other than the nursing director, we have a nursing officer, a pharmacist, surgeons, as well as a biostatistician who is very helpful with our data. Looking at the key activities in 2025, we could pen down the Antimicrobial Stewardship Core Committee's rules. We revised the work plan to include various activities. We prepared an AMS round form. With the help of the data analysis, we prepared the first local antibiogram. And during the meantime, our institution was established as a regional pharmacovigilance center too. We conducted 2 rounds of NAPS in the initial months, followed by AMS rounds, which were weekly or fortnightly. Then for the institutional strengthening, we needed documents to refer to, and peer hospital formulary with a list of antibiotics following the AWARE category were formed, and also the National Antimicrobial Treatment Guidelines were updated to form the local BEAR guidelines, including infectious disease specialists from various institutions and all the different department heads or representatives from our own institution. For capacity building, we conducted various rounds of antimicrobial stewardship training and also conducted a diagnostic stewardship orientation. Then independently, we conducted the NAPS midterm review. So in the future, we plan to introduce AMS champions to take this work forward. Talking about the key strategies and interventions, we took it forward by educating most of the staff in our institution, by conducting various surveillances, including infection prevention committee in it, AMS interventions, as well as monitoring and reporting of the. So for education, we started by the AMS orientation sessions. First, we started with the governance committee, then the heads of departments, and then we included the various residents, clinicians, and other prescribers, along with healthcare personnel from pharmacy, laboratory, even collection at times, to train them on antimicrobial stewardship. The antimicrobial stewardship program findings were disseminated in the grand round, and we also conducted the diagnostic stewardship training. AMSP as a topic has also been included in the continuous medical education being regularly conducted since a long time in our institute, and that is taken forward through CMEs and CNEs. The novel thing we did was we went to a private hospital where they have an established antimicrobial stewardship program and could get an idea about how to run the program more efficiently. These are some of the picks. For surveillance, we have been doing the hand hygiene monitoring since a long time, healthcare-associated infection surveillance, and the 3 rounds of PPS helped with the surveillance too. Talking about the National Antimicrobial Prescribing Survey, the first 2 rounds were conducted with the help of experts from Doherty Institute, and they had been there for the rounds and trained our staff and helped us with analysis of the results. So the first round was conducted in May 2025, followed by a second round in September. The midterm NAPS was conducted by the Beer Hospital team independently of the experts, but they were available online. And because of the time constraint, we could do it only in 4 of the departments. If you took the first survey as a benchmark, we could see improvement across most components of the survey, and this is what it shows. The number of audits were higher in the first two because we covered more departments, but appropriate antimicrobial use does show a slight increase. Inappropriate antimicrobial use shows a mild decrease. Compliance with the guidelines has increased a bit, but the documentation of indication was something that showed a good indication of increase. Appropriateness of surgical prophylaxis and optimal antibiotics also showed a positive increase. Only the directed therapy showed during our audits a decrease. Looking at the interventions, we started with providing feedback to most clinicians. Then we started conducting the weekly AMS rounds, which turned out to be fortnightly at times, and inclusion of AMS findings in the grand rounds that are being conducted monthly. After every AMS rounds, we had meetings with the prescribers, trying to get the heads of departments also in, and we provided the feedback on what we had found during those visits. For the outpatient departments, we did the antibiotics prescription review through the data that is available through the medical insurance in our institution. And local antimicrobial treatment guidelines helped us with those. These are a few of the pics that we took of the workshop for the local antimicrobial treatment guideline and the various rounds that we had conducted with the dissemination of it. Talking about the key achievements, we have dedicated staff for antimicrobial stewardship in our institution, which includes the governors as well as the core committees. And it's not person-based, it's post-based. So even if me as a microbiologist is not around, another microbiologist will take over. We also could prepare the hospital antibiogram and update it. We had the hospital formulary established, local antimicrobial treatment guidelines prepared, and distributed to the clinicians through soft copies as well as an app. So the mobile app was recently prepared, which includes our local BEAR guidelines as well as a link to the national guidelines. So this is the official launch of our hospital formulary and endorsement and dissemination of our guidelines for BEAR hospital antimicrobial treatment. This shows a screenshot of the mobile app that is being used now, which includes the national antimicrobial treatment guidelines and the BEAR hospital treatment guidelines. Now to talk about the challenges we faced, the issues that we have, the constraints we have, and what do we look forward to, I'll hand it over to Associate Professor Sangita ma'am to take it further.
Talking about the challenges in MSP, there are many challenges. One is financial stability, because though the leadership has given the commitment that they will find the financials for antimicrobial stewardship, we do not have a separate budget heading for antimicrobial stewardship. So we have some financial availability for resources and training and other activities. We have used that. There is a need for dedicated clinical pharmacology personnel, because having a clinical pharmacologist that will help us in stewardship. And antimicrobial prescription behavior change is another issues in our scenario, because though we have been able to present our findings to the government's committee, we do not have been able to restrict the antimicrobial uses. It is in the paper only, so it is very important. Another issue is data management and EMR integrations, and also the standardization of clinical form. Though we have made a step in recent time by preparing the new requisition forms for various tests, and also we have modified the Cardex. This is still the issues. So another is lab strengthening and sample quality. That has been also the issue, because though we have given orientation to various staff on sample collection and transportation guidelines. Another issue is leadership commitment, which has been a challenge as well as support, because we have the support of previous directors, but they have been changing in a regular basis. So that is why this is a challenge for the current scenario as well as for future. The lesson learned are that hospitals like ours, who have dedicated trained capacity, can independently conduct lab survey at a regular interval. We have dedicated multidisciplinary team to be able to do that. We have to have a departmental structure ensuring the accountability of actions, and regular AMS around audits and CME do help to improve the antimicrobial use that has shown in our case. Multi-departmental collaboration enhance the effectiveness of any antimicrobial stewardship program, and clinical leadership strengthens our contextual in our context is very important. So way forward, leadership from the institution as well as from the ministry is required. We need them to be able to tell us that antimicrobial program has to be in place with the dedicated budget and staff. We have to have an awareness program and education to all the healthcare staffs with self and joint assessment regarding the antimicrobial stewardship program for the assessment, along with the specific NAPs such as surgical NAPs and antimicrobial use services. We need to be able to integrate our data electronically. We have to have a future AMS champion who can take this work forward in a sustainable manner. And in last not but the least, we have to have a diagnostic stewardship to be able to have a functioning antimicrobial stewardship in place to ensure the patient safety. So structured implementation plan is also required for holistic interventions to be placed with the formulary restriction and pre-authorization, the vision of guideline in place, communication system for another organization, and also a feedback mechanism that is very important in the structured implementation plan. I'd like to acknowledge all who have helped us during the various activities that we have done in Bir Hospital. Thank you so much.
Thank you to our speakers there. Two really great presentations. This is going to be hard to top for the next section. Now we move on to our live panel. So we have Dr. Nimesh Paudel and Dr. Rod James with us. Just a quick introduction for each. Dr. Nimesh is a clinical microbiologist with over 15 years of experience in public health, medical education, vaccinology, and AMR research. Currently leads the AMR department at the International Vaccine Institute, or the IVI, where his work focuses on strengthening AMR systems, building technical capacity, advancing advocacy efforts, and promoting the role of vaccines in reducing the burden and impact of AMR across Asia and Africa. Dr. Rod James is also a clinical microbiologist by background. He is the Director of Clinical Services at the Royal Melbourne Hospital's Guidance Group and the National Centre for Antimicrobial Stewardship, and is a co-lead of the AMR theme here at the Jyoti Institute. And much of his recent work has focused on AMS capacity building across the Asia Pacific. Thank you both for joining us. All right, maybe
Thank you for having us.
Perhaps, so to start, maybe you could tell us what pulled you into international work, and does your clinical background shape how you approach it? Maybe Nimesh, you want to start first?
All right, thank you. Thank you for the introduction. And I worked as a clinical microbiologist in a hospital for almost a decade before I moved to international public health. I realized during my work that generating laboratory data is not enough. You need to have like a coordinated multi-sectoral approach. where everybody should be involved in order to implement policy. And that's where I realized it's important that I can contribute in international sector, particularly with my background and AMS being a clinical microbiologist, a clinician. Clinical background always was central to my work. So I always was interested to identify how intervention helps to make better clinical decisions and improve patient care. And that's why I took this as a research as well as my capacity building support that I could extend to the countries. And that's why I got interested in this area.
Thanks, Dinesh. Sorry. Rod, perhaps do you share the same sentiments as Dinesh?
Look, yeah, and I think from my point of view, and again, working in the microbiology laboratory, we're seeing increasing resistance happening in Australia and across the facilities I was working in. And I guess I really wanted to help more nationally as to what we could do to actually stop these resistances increasing. And then we work with the National Centre for Antimicrobial Stewardship and the guidance group based in Melbourne. We created the NAPS program. And I think that was where we really started to try to change antibiotic prescribing practices based off the appropriateness of prescribing in Australia. Of course, Australia is not, although it is an island, it's not isolated. So we are seeing a lot of resistance coming to Australia from our neighbouring countries. So it was therefore a very easy transition to start to work with our neighbouring countries to try to also improve some antibiotic prescribing practices. Thanks to the wonderful funding from both the Fleming Fund and BFAT, so they're a UK aid-funded program and Australian aid-funded programs. We are seeing increasing ability to work with our partners in these countries, and particularly our success stories being Bhutan and Nepal, which have just really taken AMS on with a real passion. And our great leaders like Sonam and Jyoti, who are able to affect change in their countries, and it's really wonderful to see. So I think working with these wonderful people is very rewarding, and I hope we get to do it for a lot longer now.
Thanks, Rod. So you both have this sort of, from a very small lab point of view, you've moved to this national, standpoint. Perhaps the next question would be, when you start working with a country on its national AMS program or the AMR action plan, how do you determine how it would work in the particular setting that you target? Perhaps you can answer this one first.
Did you ask me to answer first, Ron?
Yeah, we couldn't work it out.
Nimesh, you can go ahead if you like.
Now, please, Rod, you go ahead because you have it.
Perhaps any ideas that maybe look good on paper that maybe might not survive in a real setting. Have you had any of those sort of experiences?
I'm not able to hear you properly. Maybe Rod can go ahead and then I can answer. Please.
Yeah.
I think it's just so important when we're working with our neighbouring countries to really allow them to have a very important say in what is happening in their own countries. They know their hospitals better, they know their governments better, they know what's happening. So whenever we go in with our first body of developing a work plan, we do a co-designed work plan with clinicians in the hospitals. We work through the laboratory staff, pharmacists, infection prevention and control practitioners, nurses, doctors, hospital level executives, and also with ministries of health to make sure that the work plan is appropriate for each country, that's not overly ambitious, that it works in the constraints of those facilities and their abilities. They're all extremely busy people, often much busier than what we see in Australian hospitals. So doing excess work, excess training is always a difficulty. So we make sure that the training is not overloading those people, but we're making sure they're also, with those programs, that the hospitals allow them to have dedicated time to either come to Melbourne for training or for us to go across and do training in countries, to really make sure that we're not overstepping our mark, and we're doing it culturally sensitive as well. So making sure that we do a culturally sensitive training and work plan development.
Thanks, Ron. Thank you. Answered that quite comprehensively. So I'm happy to move on to the next question. So perhaps Nimesh, direct to you now. If you had to pick a single biggest enabler for AMS, what do you think that might be if you were to implement local, at any level, local, international?
I think the biggest enabler for AMS is obviously the multidisciplinary collaboration, right? It's not one person or one team that can lead to a success of implementation of AMS. All of them have to come together, the laboratorians, the clinicians, the nurses, and also the policymaker, decision makers, the leadership. There should be a strong support from there also. But additionally, I see, I've worked a lot in LMICs. There is a trust issue also. The clinician never trust the laboratory data. Either they say it's too late, we need to institute the treatment as soon as possible, or they say that we don't believe in your laboratory results. That's very honestly speaking, candid observation that I have seen over the period that I worked there. So I think if there is a clinician trust with the data, that the results that are being generated, that also enables the implementation of the program. So I think these 2 points I'll say is one of the biggest enabler for success of any AMS program, particularly in LMIC settings.
Perhaps maybe I'll put a bit more on that. So how do you overcome that? Is there a particular, do you get buy-in from certain people in order to get the trust of the wider majority, or?
Yeah, so obviously buy-in is required, but I think the collaboration is important. There should be a communication between the laboratorians and clinicians. Frequent and effective communication mechanisms should be established. They both should know what's going on and the results, how they are being generated, and whether these results are quality controlled or not. And also, they should work very collaboratively in order to make sure that the need of the clinicians are addressed by the laboratorians on timely basis also, because when you work in clinics, when you work with the patient, every second counts, right? And that's where I think that leads to the communication leads to a rapid treatment or changes in the treatment plans, which will obviously benefit the patient, and obviously the trust will be built. But again, there is a need for advanced technologies, but these technologies will not work. So you have to have that behavioral changes that needs to be done. And that comes with the advocacy, communication, and a collaboration. I'll say that's how we can overcome the barriers.
Thanks, Dinesh. Rod, do you have anything to add? What do you think might be the single biggest enabler, perhaps besides collaboration and a multidisciplinary approach?
Well, I think that those are the two things. I think also particularly in some of the countries we work with, some of the hospitals are a lot smaller. The governance structure is a lot flatter, so everyone knows everyone. They're more collegiate, and there's not a lot of hierarchy. So that often we can get programs implemented much quicker, particularly in the smaller hospitals. And I do think here there's I think more passionate people. Often that they're really seeing a lot of death and mortality associated with antibiotic resistance, much higher than what we're seeing in Australia. So the urgency is there a little bit more as well. So people are really wanting to work together to try and improve the processes in their facilities to make sure that they do see decreased antibiotic resistances. So I think that urgency, along with able to communicate much easier with their fellows, I think with a much flatter structure often helps setting up these programs.
Thanks, Scott. Got a question from Cass here. Cass, do you want to unmute yourself and ask your question yourself, or I'm happy to read it out if you like?
I'm happy to unmute and talk. Hello, Nimesh and
Very
Ron.
good.
Thank you. They were fantastic. And I'm just reflecting back on when we first started with Pem Chuki in Bhutan many years ago, how proud she must be to have seen what they've achieved there. And I actually had the opportunity to visit in the early days of the Fleming Fund, and it was very impressive. Interestingly, though, Bhutan and maybe Nepal's the same. There were a lot of expats from developed countries manning the hospital that I went to anyway. And maybe that does make it a little easier to have the skill sets to execute some of their programs. I don't know. I'm just saying that just because I was aware of the quality of some of the surgeons and clinicians that were working there. My question is, what happens if there really is a key gap? And I'm reflecting on pharmacists who are such an integral part of antimicrobial stewardship. And I'm sure in Australia we have more AMS pharmacists per capita than anywhere else in the world. But, that's not the same in LMICs. And that's we as program leads can't always shift the dial there. So how else can these resources be obtained, I guess, or built up? And do the international pharmacist federations and other groups, how are they going to help the AMS cause? You may not be able to answer that because we can't always shift the dial on everything that we need to have an effective program.
Yeah, and that's definitely what we see in lots of our neighbouring countries is that they don't have a very strong pharmacy workforce. Pharmacists are seen as dispensers only and rarely as clinicians. In Australia and other Western-style AMS programs, it's often the pharmacists which are leading them, whereas in some of the countries we work with, it's definitely the clinicians. They've got to do this on top of their normal workload and ward rounds. We know the clinicians in these countries are very busy, so AMS often does take a back step, unfortunately. There is a bit of a interest in trying to improve the clinical pharmacy support. Some of the countries are seeing is that there's every now and then you'll see a clinical pharmacist, which is really good to see. They don't always have an AMS job, but we are encouraging them to take on those and to increase their ability to have more clinical pharmacists. And we are seeing a few, particularly AMS pharmacists from Australia, going and working in these countries and helping to support and to build up that capacity. Our wonderful Deb Tong, who now works at WHO, she did a lot of work in the Pacific region as a pharmacist, trying to encourage pharmacy staff to take on those more clinical roles. And we are seeing that, particularly in Fiji, where she worked very closely with the pharmacists, we are seeing some clinical pharmacists creeping in. So it is going to be a slow process. There's not much funding for them. The universities aren't set up so much to build clinical pharmacy. We are seeing it a bit more often. So hopefully, in the future, we'll be seeing the pharmacy workforce be able to support AMS more strongly. But at the moment, yeah, it is often very clinician run. And as I said, with busy clinician life and workloads, AMS can unfortunately take a back step. But I do think with programs like the Fleming Fund, like Combat AMR, other ones in the region, that does allow them to have a bit more space to do these programs as they get the extra funding and extra support. So I do kind of, unfortunately, in the political sphere at the moment, we are seeing less funding for these kind of programs. But in particularly the DFAT from Australia is continuing this, and it's fantastic to see. Yeah.
That actually was going to be my next question to Nimesh, actually, because, from us sitting here, seeing the USA funding and other funding withdrawn, what do you think needs to happen, Nimesh, in terms of supporting these countries, given that the NGO funding is so precarious at the moment?
Yes, that's a difficult question, I'll say.
Difficult question.
Yeah, I can say from my VI's point of view, we are actively engaging with the countries, even though the funding resources are not available. These days, virtual support is pretty much acceptable and a very effective way to engage. And we're doing that beyond the existing funding envelope that is available. But nonetheless, we're also kind of seeing what the country's resources can support and how we can kind of contribute on top of that. Also, these collaborations and the consortiums that we have built up, the relationship that we've built up over a couple of years, I guess is a very strong indication to reach out to existing funders or even non-traditional funders that we can reach out to and see if they will be interested to scale up on the investments that has already been made. I see that with the Fleming Fund and other funding investments that has been put in place for last decade, the requirement will be much more lesser than the initial investments that was required. So I think there is a hope, silver lining, even though funding has decreased, and that we will be able to continue working and supporting the countries that we have engaged with earlier and expand it also.
Thanks, everyone. We might move on to the Q&A section of this session. We have some questions in the Q&A box. Some are directed at the speakers who unfortunately couldn't join us this morning, but we're happy to direct it to you, Nimesh, and even Cass, if you'd like to join in as well. So the first one comes from Anna. It's, what is the main advice you would give to other clinicians wanting to implement better IPC and AMS? Lord wants to answer.
Also, I'd probably roll Lisa's into it because it's a very similar question.
Yeah, sure. And Lisa's question is, what have you learned how to get IPC and AMS teams working better together from your work in LMIC? What should we focus on in Australia moving forward?
I think that second point, I think that second point is very important because Sonam, our first speaker, she was actually head of AMS and IPC. And we do see a lot of that in LMICs where that role is a combined role. And I think it's actually really good to see. Of course, it makes Sonam's job, and also as an infectious diseases doctor, extremely busy. And you know, over time, you would hope to see that would maybe split to have a bit more resources. But unfortunately, small hospitals, small workloads, often it is the one person with many hats sharing that workload. But I think that it just shows that how important and how it's seen in LMICs that IPC and AMS is really so closely linked that it's often the one department or the one role taking on that leadership. We're seeing that in other countries as well, where it is often the one person who leads both of those programs, and often a doctor. I do think that what we try to do is, and I think Nimesh said earlier, all our programs are multidisciplinary. All our meetings, we try to be multidisciplinary. We have doctors, pharmacists, IPCs, and laboratory staff all in those meetings. And I think that's so important to break down those silos and those barriers. Often programs are implemented in pillars, and often that kind of actually causes them to be broken apart a bit. So what we try to do is really make sure that we integrate all of those pillars into the one meetings. So we really do foster those collaborations and making sure everyone understands what everyone else's role is, what everyone's doing in the hospitals, and they don't feel like they're working in a silo, and they don't feel like they're the only person with the burden of AMS on their shoulder, that it is spread and it is a joint effort across all those different organizations. But Nimesh, what are your ideas as well?
Yeah, I agree with you, Rod. The advice I can say, if I was working as a infectious disease clinicians leading IPC AMS, is to make sure that all other clinicians, as well as the infectious disease doctors, realize and understand why it's important to control resistance bugs, right? It helps their life, I'll say, right? That as there is effective AMS and IPC, the treatment becomes easier, the identification of drugs, bugs, and the burden on the part of them also decreases. So as they become aware, they will try to imbibe and imitate what's required, and they'll take it over. So I think the more important thing is advocacy and trainings and making sure that the program's objectives is communicated to all in the country and beyond.
Thanks, Ron. The next one comes from Verily Thomas. It's, what are your views on AMS in the community, particularly aged care, where the antibiotic burden does contribute to community-based resistance, but also inadvertently affects hospitals? The question's particularly targeted on limitations in formulary restriction and pre-authorization targeted at GPs, where there is no ID feedback and support.
I can say probably this question is more to the systems, healthcare systems, where GPs are the focus and communities, but there are public health and primary care centers in LMICs also, which are manned by the bachelor's level doctors that probably won't have a GP experience, and the burden of the use of antibiotics probably will be very limited in primary healthcare centers in LMICs. I cannot say it for sure because there is no documentation processes in most of the LMICs, but even if a national or guidelines are available on antibiotic use and AMS guidelines are available, and that can be strictly enforced up to the primary healthcare level, it will be easier to monitor those and make sure that the appropriateness and guidelines following the guidelines will help control the resistance problem and misuse and overuse problem at the primary healthcare centers levels in LMICs. But Rod, you probably can give an example or experience in Australia, how it's done, and if it's applicable or replicable in the countries where we work.
Yeah, I do think that communities are always going to be slower and behind hospitals. Hospitals have the staffing, they have pharmacists on site, they have doctors, they have AMS rounds, they have services dedicated to improving antimicrobial prescribing. These are less so in community. We are trying to, I guess, boost these up, particularly in aged care. As you point out, it's a very important one because the aged care residents do have a higher rate of engagement with hospital systems. And we are slowly seeing AMS creeping in as now part of the accreditation requirements for aged care homes in Australia. There's also a capacity to increase the pharmacy services to aged care now, and the government's really trying to fund those and trying to see more pharmacists being involved at the coalface in aged care homes. And so I think over time we will start to see AMS programs creeping in. It is difficult to access the GPs, as you've kind of rightly pointed out. They do sit outside of the aged care homes. They don't have those requirements on their shoulders so much, and they do, I guess, have a freedom to prescribe a little bit outside of the aged care home, as they are kind of seen as an external provider rather than as staff. So I do think the setup is very difficult to implement antibiotic stewardship programs in communities in Australia, and even worse in LMICs, where, as I said, the GPs are extremely removed. They often over the counter. Without prescription medications are still very common in a lot of these countries. So people just walk down to the road and get their antimicrobials for their themselves or their families. So it's a much difficult question to, I guess, address. And it's happening a little bit slower, but there's lots of things happening. The WHO is putting out guidance around such things. We are trying to limit the amount of over-the-prescription prescribing in certain countries, and that's improving, I guess, access to more appropriate antibiotic use. So it is a very good question and very difficult to answer, but I think particularly in Australia, we're seeing some progress. It will be more difficult in other countries, but hopefully over time we'll see those processes improve, and learnings from the hospital sector can be transferred across to these, hopefully with a bit more time, a bit more funding. We'll see some improvements.
Just one more thing to that discussion as well. I think a big part of it is documentation. I think in Australia, at least, we have a sort of paper trail whenever something is prescribed, whereas in other settings that doesn't exist at all. So even tracking or can understand the big picture, it's virtually impossible. So it's something we can work towards. All right, we're just about out of time, I think. It's 9:25 now. Anna and Lisa, I will forward your questions on to our speakers, to Sonam, Jyoti, and Sangita, respectively. And perhaps we'll draw to a close now. So huge thank you to all our speakers today, Dr. Sonam Zangmo, Jyoti Acharya, Associate Professor Sangita Shrestha, and all our panelists, Nimesh and Rod. Thank you for your time and your contributions. As a reminder, the recording of today's session will be available on the NCAS website. And please join us again on Wednesday, the 19th of August, where the theme will be audit and feedback. Any final words, Nimesh, Rod, and Cass, if you want? We have 4 minutes if you like.
All I can say, if anyone gets the opportunity to work in LMICs in the region, it is extremely rewarding. Would highly recommend it. The people are so appreciative of any help and education, and they're in dire need, particularly pharmacists, particularly nurses, IPCs. Anyone who's online and has ever thought about signing up and trying to do some work, I would highly recommend it.
Feel free to reach out to Rod or Nimesh or Ron. We are always looking for people who are interested in learning how to do implementation in these environments, and I agree. And also a shout out to these people on the screen, because I know just how dedicated and how much work they have been doing with IBI and the Fluing Fund for several years now. So congratulations also on the outcomes, and a shout out. I don't know if you spruiked this, Ron, but we had a paper published this week that Ron led. It was a bit like herding cats, but we were able to pull together a beautiful publication about the implementation experience of NAPS across three sites.
It's a collaborative effort across 3 different countries and very different time zones. So thank you to everyone who collaborated, and Rod, Nimesh, and Cass are part of this paper too. Nimesh, thanks for joining us. Good to see you again. I'll see you at work, Rod and Cass. Thanks everyone for joining.
Thank
Good Wednesday.
you. Bye-bye.
Thank you, everyone.
Bye. Have a good day.